All right, well, good morning, everyone. Thank you for coming back to day 2 of North 2021. We have a busy day of seminars planned for you today. So we're going to kick it off this morning with a keynote from Dr. Brad Price at University of West Virginia. You are all in Zoom session 1 if you are here this morning. After this Zoom session, or after this first keynote talk, we will be splitting into sort of 2 tracks, and you are welcome to join either track for any of the sessions. And so you just have to make sure that you join the correct track for the speaker that you're looking to watch their seminar for. So if track 1 will stay in this same Zoom session that you're in right now. Track 2 will have a slightly different link. We'll put these up at the end of the talks just to remind you which session to join. And we'll try to throw them in the chats as well, just in case people don't necessarily see that, or you can just refer to your email that you have from last evening. So we will try to stay on time and make sure that we have all of the breaks that we've promised. But again, please drop questions in the chat if you're not sure which speaker you want to see next, or you can't remember which Zoom link. We can definitely paste that multiple times. And just to remind you how to ask questions. So putting questions in the chat, provided we don't have any catastrophic Zoom failures, the moderators will help ask the questions to the presenters. And make sure that they get to those either during the talk or at the end. And we can do a little bit of live Q&A with the unmuting if you raise your hand at the end of the talk. Just again, a reminder that this is being recorded. If you want to remain anonymous, rename yourself, keep your video off. But I think the speakers, I know I enjoyed seeing people's faces and getting a little bit of the live reaction feel. So please go ahead and show your video if you're comfortable with that. All right, so with that, I'm going to jump in and introduce our first speaker for the day. Dr. Brad Price is an assistant professor of business data analytics in the Management Information Systems Department at the College of Business and Economics at West Virginia University. He received his PhD in statistics from the University of Minnesota School of Statistics. He is currently leading data analysis and data science initiatives as the chief data scientist for the state of West Virginia Governor's Joint Interagency Task Force on COVID-19. During the early parts of the COVID-19 pandemic, Dr. Price and other colleagues from Data Driven West Virginia were awarded a Civilian Service Medal Award for their work developing models and technology to forecast demand for personal protective equipment. It's my pleasure to bring you Dr. Brad Price for this keynote this morning. Thanks for joining us, Brad.
Morning, thanks for that introduction. I'm gonna go ahead and share my screen here so everybody can kind of see the chaos a little bit. So it's great to be with you. It's great to be here, especially talking at this conference. I was telling the organizers earlier, or Lindsay and Christina, just how much I do appreciate this conference and how great it is. And it's one of those things I'll probably keep coming back to over and over. I do want to thank them for the invitation to speak. I also told them I don't like talking about what we're doing right now. And if it wasn't for them asking Lindsay, Christina, Lisa, I probably wouldn't do it. Just because this is kind of a touchy topic right now, but I think it's something we do need to talk about. It's a conversation we need to have nationally. And I'm going to highlight some things maybe you haven't thought about in the COVID-19 pandemic coming from the side of actually working it for the state. So I'll give you a little bit of my background. I'll give you a little bit of my story, but I've tried to put together this talk in so many different ways. And then I finally settled on, I'm just going to tell the story of what happened, because that's the easiest way to tell this. So the first thing you need to understand about me is I'm a hillbilly from Upper Hollow. I'm originally from West Virginia. I'm from Southern West Virginia. I'm from the coal fields. And I know that sounds funny, but it's true. When I first came to Minnesota, I had never been on a plane. I come from one of those places. Christina has one of the better stories, but to say my accent has gone away would be a fact. you know, if you think I have an accent now, you should have heard me at 22 when I got to first meet some of these people. But where the story starts is kind of there. One of the things you have to understand about me as well is I owe everything I have to the state of West Virginia. I'm from here. I'm originally from here. I'm a product of the public education system in West Virginia. I got to go to WVU for free because I'm from West Virginia. And that set me up an opportunity to go to the University of Minnesota. Now, Minnesota holds an extremely special place in my heart. I'm a big fan of Minnesota and the cities and the people and everything up there. I always tell people, besides marrying my wife, the best decision I ever made was going to the U. And those guys had those professors and the people we went to school with had a huge impact on me, and I'll forever be grateful for that. And I want to kind of start this conversation off with a quote from Charlie Geyer, of all people. Charlie was one of my co-advisors, and I think the world of Charlie. But Charlie once told me, I was getting really frustrated at my research, and Charlie once told me, listen, calm down. The most important thing you're ever going to do is teach. The biggest impact you'll ever make is your students. And prior to the pandemic, I'd have probably thought, yeah, that's true. And I was a big believer in that. Now, I don't know. I'll leave that up to other people to figure out. But what we've done over the past year, I'm extremely proud of. Is it all optimal? No. We're building a plane while we're flying it right now. You know, one of the things over the past year, and I'll hit on this again, that I've learned and that I will continue to think about is we talk about critical infrastructure in this country. And if anything's been pointed out to me, it's that healthcare technology and public health technology specifically are a huge piece of critical infrastructure that we need to continue to invest in, especially around data infrastructure and the things we need to do. I know this is a conference on R, but what I want to frame the conversation as today is a bigger conversation about how are we using technology to solve these problems, because it's just not R or anything else. R was our tool of choice, but we had to figure out how to play nice with all kinds of other systems and data that didn't even exist. So there's conversations we're going to have. There's things we're going to talk about. There's things I apologize I can't answer, and I'll explain why. There's things I wanted to show you that when I had these slides reviewed, they pulled about 10 of them out on me. So we can talk about it. I'm more than happy to have these conversations. And when I say they pulled 10 of them out, some of this is considered a security risk because of vaccination and where it is and how we built the cybersecurity around it. So again, I want you to understand some things about how we're going to approach this today. Currently, I'm an assistant professor in business data analytics. I did submit my tenure packet yesterday, which was, one of those, like, am I going to hit the send button? I'm also co-director of the Biostatistics, Epidemiology, and Research Design Core at the West Virginia Clinical and Translational Science. On top of that, chief data scientist role. And if you guys aren't familiar with the GIADF, I'll talk about that here in a minute. So the other thing I want to do is I want to let you know, I can't give this talk without talking about this guy just a little bit. For those guys who don't know him, this is Jim Harner. Jim Harner was one of my mentors when I was here at WVU. He's the guy who actually talked me into majoring in stats as an undergrad. About 2.5 hours when I thought I was going to be an accounting or aerospace engineering major, I spent in his office. If you ever met Jim, he could talk your ear off and convince you of anything. And the thing I appreciate most about this picture is, if you don't realize it, he has 2 Macs sitting on his desk, and both of them are running at the same time. And not screen share, not anything like that. Jim was a big computational guy, and rather than share my GitHub today, and you guys can find me, it's on my webpage, it's all that fun stuff, I'll share Jim's. We lost Jim in February to COVID. He contracted COVID about 3 days before he was eligible to get a dose in West Virginia. So if you don't think I'm wearing that a little bit when I talk about this stuff, you're out of your mind. This is personal to me. I'm from here. I started here. I'm working here, and I plan to spend the rest of my career here if I'm able to get tenure. But the things I need you to understand is we do things a little different here. So I'm going to set up the state. I'm going to set up how this works. And I appreciate y'all coming today. Appreciate y'all listening. If you have questions, feel free to ask. I'll answer what I can, but I'm not one of these people who's scared to say, I don't know. Because there's some things about this we still don't know. There's some things about this I still can't answer. So if I'm going to tell the story, I better introduce you to the characters, right? Please meet 3 of my favorite people on the planet. Miss Darianne Drake, Mr. Ryan Midkiff, and Miss Catherine Kopp. They made up at the time what was called Data-Driven West Virginia. And I'll tell you about Data-Driven West Virginia here in a minute. The thing I'm most proud of about this is all 3 of these are my students. All 3 of these are my students. All 3 of these are Jim's students. So when we talk about this, understand the footprint here, understand what it's about. Catherine is now the director of Data-Driven West Virginia. Ryan is now our customer success data scientist. I never get that title right with Data Robot. And then Darianne is now the director of our diversity and inclusion initiatives at our college. So I'm really, really excited about what they're doing and how they're doing it well. But at the current time, Catherine was a data scientist, Darianne was a data analyst, and Ryan was our GA. So that's how this all started. Some other players you need to know. Data-driven West Virginia. Data-driven West Virginia. Data-driven West Virginia supports the state of West Virginia in advancing its causes, communities, and corporate efforts through providing data-driven technical insights and analytic solutions. I left the University of Miami in 2016 to come back to West Virginia. And one of the reasons I wanted to come back here was you don't really think about technical capability in data science when you think about the state of West Virginia, right? I had to leave West Virginia because I couldn't find work here. We're energy based, right? It's oil and gas here. You guys will even see over my right shoulder, that dark thing sitting back there, that's a piece of coal. It's a piece of coal art. Like that's what we're known for. And that's great. That's awesome. But we've got to start creating jobs in different ways. I came home to try and help fix it. And for the first few years, it was jousting the windmills. Now we've had some help come back in Brad Smith from Intuit and John Chambers, who was with Cisco for a lot of years, who's doing a lot of great things around here and graciously named our college. But we've had some help lately and it's been great. But one of the things we wanted to do is we wanted to start exposing students to the technical problems that exist in industry, not just make it classrooms. So what we did was we created Data-Driven West Virginia. And the reason I say that isn't to promote our programs, is to tell you that one of the reasons we were able to respond to what we were able to respond to was this initiative, was we had been exposing students to these technical problems, was we had been showing them shiny, was because we've been teaching them how to program in R, was because we talked about disparate data sources and how you combine them and what you need to think about and how you need to approach these problems. But the other thing is we taught rapid response. You have a problem to solve, you have to solve the problem. It'll never be ideal. What are you going to do? The other group I got into with this was the West Virginia Clinical and Translational Science Institute. It's a CTR. And basically what that means is its job is to help rural areas in healthcare. And what we really focus on in this group, and this is how I got picked up in the what we call the BIRD core, biostatistics, epidemiology, and research design, was how do we use like modern statistical tools to solve these problems. And anytime I give these talks and anytime I talk about it, I have to put the grants on here and tell you none of this, the NIH isn't endorsing a bit of this. And there's some things I might say that they might not like right now. So as we go through this, just kind of keep that in mind. The other players you need to understand in this are Hannah Bailey, John Saldana. Hannah is a data analyst who helped us program a lot of what you're going to hear us talk about as far as vaccine response. John Saldana is a supply chain professor here at WVU who we had a lot of conversations with when we were doing our PPE forecasting. We've had amazing partners at the state level. A lot of them being the West Virginia Department of Health and Human Resources, and Josh Wayne and Tim DeBar, who are the data analysts and data scientists there, have been phenomenal. Major Ryan Koss, who plays a critical role in this, we'll also talk about. The LT himself, Lieutenant Oliver Wiegand, who's a data scientist with Northrop Grumman, who now working for cybersecurity for the DoD. Members of what we're going to call the JIATF, the Joint Interagency Task Force. This is a concept that I'm going to get you guys pretty familiar with. And the state of West Virginia in general. If you read the popular press right now, you'll hear that West Virginia's vaccination isn't going great. It's not as good as we'd like it because we don't have 100% vaccination. But some of the numbers that are in the papers of record right now, I have a strong disagreement with, and we're going to spend some time on that at the end because that's a data problem in itself. So I want to make sure we're talking about it. Other people, Salman Nazir, Nandra Surendra, who helped us kind of formalize what we should be taking away in the software design and the systems we've developed from a theoretical and academic standpoint. And then WVCTSI's BIRD course specifically, I want to thank Dr. Sally Hodder and Wes Kimball. They've been 100% supportive of everything we've tried to do to crack this problem. And as we go through the problems we've solved, or attempted to solve, I won't say we've actually solved anything. I'll let you know how they've played their role. So that's everybody who was involved at the highest level. And then there were a bunch of people like first responders and vaccinators and the West Virginia National Guard who have played a role. And I want to make sure we say thank you to them today too, just because they're the ones on the front line of this entire thing. I'm just building tech on the back end. So what major projects have we talked about? And we're going to highlight just a few of these today. When I tell you, I think I've touched every piece of data that is possible with COVID. don't think I'm lying. We've worked on everything from PPE forecasting to testing rates to getting tests into the right areas to vaccination to vaccine hesitancy to what treatments work best with COVID, working in the National COVID Cohort Collaborative N3C, which is sponsored by the NIH too, and I can just keep rolling. To say COVID's dominated my life for the past 18 months would not be a lie. Some of the people I've talked to, you know, Christina and I've had a few conversations on this about just what I was going on, because you need those sounding boards during that time. And I've got a lot of sounding boards and a lot of people have been great. You know, Christina's one of them. Ben Sherwood, who's at University of Kansas, is another. He and I write together a lot, and he had to listen to me rant and rave about all the fun stuff going on. But the major projects we've kind of worked on during this, we worked on forecasting personal protective equipment in an emergent pandemic setting. Now, we're going to spend some time talking about this today, but one of the things you need to understand is, how do you forecast with no data and no idea of what's going to happen? Put yourself back in April 2020. You got to try and prep for a pandemic that is coming to a state that is ranked 50th in the Kaiser Family Foundation health rankings. What that means is COVID should have ripped through this state and decimated us. When you're prepping for that type of environment, how do you do it? The answer is, I still don't know, but I'll show you what we did and how we solved it, or we think we solved it. We also worked on forecasting localized COVID-19 outbreaks using an epidemiological take on an LSTM model. So how do we take some of these machine learning models and make them actually work for us in these low data, small data problems, right? Because we talk about deep learning, we're talking about millions and billions of data points, right? That's what we always want. We need these large sample sizes. How do you do it when you only have less than 365 data points in a time series? How do you make that work for you? We're also going to talk about inventory management for vaccine distribution using Shiny. I wanted to show you everything we could with this. I wanted to take you in the intricacies, and I'm going to take you into a lot of the concepts we used. But to walk you through all the code, right now we probably have 20 to 30,000 lines of code written just to run this application. Everything we're doing in vaccine distribution in the state of West Virginia, as far as through the state allocated doses, and we'll talk about what that means, is running through Shiny. It's running through a Shiny server. It's not even running through a Shiny Server Pro. It is running through a Shiny server that we've secured, and we've utilized the resources of the state. It costs us about $85 a month to run this application and to send vaccines out, because we can't run it on a local server. We have to put it in AWS. So yeah, it costs us money, but $85 to get out vaccines, I'm good with it. Like I'm just going to go ahead and say it. The other thing you have to keep in mind with what we're going to do, and I'll bring it up a few times, we're spending taxpayer dollars. So we have to keep that in mind as well. We've got to try and be cost effective and cost efficient in everything we do. And then the last thing we're going to talk about, given we have some time, how many vaccines have been given to West Virginia residents? Now, if you go to the Washington Post, the New York Times, or the CDC website right now, you're going to see a number that is about 1.5 million doses have been given to West Virginia residents. It's going to tell you less than 50% of the state's vaccinated. It's going to tell you we may not get fully vaccinated to the metrics people want to see until September 22. I got problems with that data. I got problems with those numbers, and I've been very loud about them, especially lately. I'm going to keep getting louder because, again, we have a critical infrastructure problem that the pandemic has pointed out, and it's not through what we think it is. It's through public health and healthcare technology. We need to make sure we view that as critical infrastructure, especially in times like these. And so I'm going to point out some of the things we've seen. I'm going to point out what we did. And like I said, I'm just going to tell you the story. So let's go back and start. Now, normally I put a cute picture up here about like what my house looked like in spring 2020. I've got a 6-year-old, a 3-year-old, and a dog running around, and it was an absolute mosh pit. Like we were building pillow forts. We had everything else going, right? But I took that picture down just because, you know, as my wife said, the house was way too dirty to show other people. So I did appreciate her. My wife, she, like I said, I told you she's probably the best decision I've ever made in my life, and how she's lived with me through this, I'll never know. But, you know, she works in an addiction setting. She works in a clinic. So she has to be there every day. She's one of the people wearing masks every day. Even through all of this, you know, there was no remote care for her. She has to be there. And in West Virginia, the opioid epidemic is a real thing. So, you know, when we start talking about this, we're not just talking about who you think of as frontline workers. We're talking about really a lot of other people who are on the periphery, who get lost. But in West Virginia, here's what we were looking at. We were looking at a stay-at-home order, kind of like everybody else. And here's what the stay-at-home order actually said. You guys can kind of go through it. We can go to the grocery store, convenience or warehouse stores. We can go to pharmacies to pick up medications. What's the difference between stay-at-home and social distancing? All of these things. Everybody got used to Zoom really fast. And a lot of people want Zoom to go away now. And you know, I'm kind of in the mix. But the other thing we started hearing a lot about was critical supply shortages. Are there going to be enough ventilators? Are there enough hospital beds? What's that look like? How does that work? What are we thinking about? So you start seeing other things, and it didn't go away. This wasn't just an April, May, June problem. Take a look down here on Money Watch. That's an October 29th, 2020. If you'd have checked Fortune 3 or 4 days ago, they were talking about supply chain issues in PPE again and why it's so important. What I'm telling you right now is that this isn't going to go away. This hasn't gone away, and it will not go away. This is a supply chain issue that we have to solve. Now, I'm like statistician's my formal training, right? I always tell people I'm a math geek and a tech nerd, and I absolutely love it. But what I've had to do is kind of expand outside my bubble and start looking at what are these problems that we actually face? Because there's a difference, as we're going to point out, between the epidemiological problems and the epidemiological models we have and the things we need to operationalize hospitals. We always talk about practical significance versus statistical significance. That's what statisticians talk about, right? I'm going to take it a step further and say, how do we operationalize that? How do we take it so people can actually make decisions and use it? We got a call. It was Major Ryan Cross on the other end of this, and here's what he said. Hey, can we predict PPE needs at a healthcare level facility and for about 10,000 long-term care facility beds? Man, I don't know. We can try. Like, what do you want me to say? And in all honesty, when he called, I was sitting in my garage working on my lawnmower because I had to tinker. I had to do something. And he called me. And I looked down. And I was like, you know, we worked together in a couple other projects. And he called me and he was like, man, I need help. I just got spun up in the National Guard. Like, how can we do this? Now, this is going to weird a lot of people out that the National Guard is who handles this in West Virginia. All right, because you see military uniforms in a National Guard perspective and everybody gets thrown away. But the National Guard here has some very specific skill sets in logistics, cybersecurity, and they're very well trained. They're smart people. I will tell you, Ryan Cross is one of the best supply chain minds in the state of West Virginia. He ran supply chain for Milan and now Milan's new name, which I always pronounce inappropriately, so I'm not even going to try. But he ran that for years out of their Morgantown office and was really well known for that. So having him as one of the leads looking for PPE in the state was a good thing. I mentioned Lieutenant Oliver Wiegand. LT at the time was a data scientist at Northrop Grumman. They spun him up to run the back end and build all the database stuff. We have cybersecurity skill sets in the National Guard here that are just outstanding. They're internationally known. They get called in to help different countries in different times of need. So it's a big deal here. But they're also the people who are known in the communities and can respond in the communities. When we have floods, when we have snowstorms, when we had any type of stuff like that, they're the ones who respond. So they're the ones who are picked up. During this time, they were also delivering food for schools. Kids were at home. You know, in West Virginia, we have a food supply problem too. We have food deserts. So we have to make sure they were getting delivered. They were going house to house. They were driving buses. They were doing a lot of different things during this time. So we get that call to hear them pick up logistics. Being from here, living here, it doesn't surprise me at all. But to other people, if you don't understand the culture here, that may weird you out a little bit. So we get this call and the answer is, yeah, we're going to try. Now, Clay Marsh has a nice little quote down here. And Clay's our COVID czar. He's also our dean over at the Health Sciences campus here at WVU. We were lucky enough. He came here the same year I did from Ohio State in a similar role over there. Clay Marsh is one of those guys, and you'll hear me talk about General Hoyer in a minute as well. And really our entire state leadership, I think, has done a great job with this. One of the areas I'm proudest of is our innovation and focus on self-sufficiency. As part of the National Guard's role in the pandemic response, they coordinated an acquisition of 6 months supply of PPE. And because many items were challenging to acquire early in the pandemic, we started to manufacture much of our own PPE. What I mean when I say operationalize this is we have to come up with forecasts for PPE, and then these guys have to go figure out how to get it. And that ain't easy. What we had people do was people could sew. They got hired. They got hired, learned how to sew. And what they did was they put together gowns, they put together masks, they put together all this stuff, right? At a scale. Because here's the one thing you learn being from here. And I'm not saying it looking for sympathy. I'm saying it looking for just an honest fact that we have to assume as we go through this. When you live in West Virginia, ain't nobody coming to save you. You're not top of the priority list. You're not top of the food chain. Think about April 2020, New York, New Jersey, Massachusetts, California, Texas, Florida. Ain't nobody concerned about what's happening here. Part of living in rural America, but it's also part of being in a state like West Virginia where there's not as many people. We have 1.792 million people statewide, 1.8 million people. Relatively, if you're sitting in the Twin Cities right now, you got more people within a 20-mile radius of you than we have in an entire state. So these are the things we have to think about because we can't rely on federal. All right, we can't just turn to the federal and say, hey, help. It's not there, especially when there are national shortages. So what we had to do is we had to start stepping back and saying what models exist. And everybody, I think, got really familiar with what was called the White House model. Came out of the University of Washington, right? I'm sure everybody lived on this webpage. Like, hey, when's it, 2 weeks to flatten the curve? When's the curve going to flatten? What are they actually forecasting here, right? Well, welcome to week 76 of 2 weeks to flatten the curve. But here's the other idea. How does that actually help me? The model's good, don't get me wrong. From a statistical standpoint, it's a great idea. But if I'm General Hoyer, if I'm Clay Marsh, if I'm any of the leadership in the state of West Virginia, how does that actually help me operationalize? Well, it says, okay, I need ventilators, I need ICU beds, I need these things. West Virginia is a big state, whether you realize it or not. It takes us 6 hours to get from one side to the other. How do you know where to put equipment? How do you know how to do these things? Well, this is a great concept. The practicality of it and the way we could operationalize it was no use for us. Here's the other thing you have to realize. From the standpoint of how long out can we forecast? Anything under about 60 days during this time period was useless. Because if we couldn't do 2-month planning, nothing mattered. 14 days isn't enough to make the changes. 14 days isn't enough to get the supplies in. You can try and get as many as you can in that time period and stock up, but it's not going to work. So while there were a lot of models out there, the actual usefulness of them for operationalizing pandemic response wasn't there. So let me introduce you to the state of West Virginia and the healthcare systems in the state. That's a big state. To give you reference, Charleston, West Virginia is right here. Ohio, Kentucky, Ohio, Pennsylvania, Maryland, Virginia, DC. We're as far south as Kentucky at the bottom. Far north, that upper tip right there is above Pittsburgh. We're as far east as DC and further west than Columbus. We got a lot of things going. It takes 6 hours to get from Charleston to the Eastern Panhandle because of the way roads run. I told you, I'm a hillbilly from up a holler, right? My holler's right here. But what you have to understand is what could be 3 miles as the crow flies is 45 minutes because you got to go around. Now, four-wheelers and side-by-sides make things easy, and these old logging roads and coal mining roads get you there. But you can't move that. You can't move supplies on that, okay? So again, here's a fun fact for you. We learned it in 8th grade in West Virginia. We have a West Virginia history class. We're all about West Virginia here, if you haven't figured that out yet. If you flatten out the state of West Virginia, it's bigger than Texas. Like I said, there's a lot of hills and hollows we got to take care of, and there's a lot of people who live up. But this is what the healthcare systems in the state of West Virginia look like. The red dots, this comes from the West Virginia Hospital Association. The red dots are the major healthcare systems. They're kind of the core or the hubs. The little dots could be anything from a clinic to a 10-bed ER. You don't know what it is. Our population centers are where you see most of the hospitals at. Here's Charleston, here's Huntington, where Marshall University is, up here, Morgantown. But really, that's about it. Ski resorts are over here, along with all the different great things you should come see in West Virginia. All right. But now, if you look at this and you kind of think about this, all these little clinics here may be able to hold 10 people, but we still have to make sure they have the PPE supplies they need, okay? The other thing we have to think about is I want you to look right here. There is not a hospital in 1, 2, 3, 4, 5 counties. They got to go somewhere. So it's not like, hey, people in these 3-block radius go to this hospital or people will come here. We have to think not only about when we're forecasting this, we not only have to think about what's the disease look like, but where are people going to go? I told you I'm from here. We had one clinic in the area, one hospital. If I had to get stitches or something, I would pull in, I would look to see who was working in the ER. If it wasn't who I wanted it to be, I'd drive to Charleston. I can promise you I've driven to Charleston to get stitches before because I didn't want to go there. People make decisions based on the type of disease they have. The other thing is we have to what we call Health Net, which is the helicopter transport, a lot of people here. So what you're looking for and what you have to consider is how people move as well. It's not just, hey, forecasting. It's not just how many beds do I need? It's where are those beds? How are people going to move? Where are the outbreaks actually happening? So you can start staffing, so you can start getting resources to where they need to be. That's the difference between prediction and operationalizing this stuff. All right. Now, first thing I talked to you about, we need to account for how people travel and for how people engage with healthcare in rural states. It's not like you're in downtown. It's not like, hey, I have 3 hospitals I could go to. You got one to get there. You got to get there. I know people who travel an hour and a half to go see their primary care doc. You got to remember, we drive 45 minutes to the grocery store around here some places. Like you go to town. Like that's what we say here. I'm going to town. And that's a big deal. All right. The other thing, PPE usage increased for more than just confirmed COVID infected patients. Our epidemiological models rely on us to test and have surveillance on everything. If you look at all of them, they will tell you, we've got to have surveillance. We've got to know testing rates. We've got to know all these things. Great. We're trying to operationalize epidemiological models with limited testing and limited resources. How are we going to do that? So what we actually saw PPE usage on, infected patients. Well, great. If we can test them, we know who's infected. But then there's that ugly false positive rate about tests, right? We don't want to talk about that, but that happens, right? And then if you're showing up at a hospital and we can't confirm you have COVID because a test takes what, 7 to 14 days in April to get a result back, I still have to treat you like you have COVID. I still have to use these PPE things. I still have to wear the N95 with the surgical mask over it. I still have to wear the ventilator. I still have to wear the gowns and change them every time I walk out of a room, right? This right here does not show up in your epidemiological models. It will not show up as a confirmed case. There's enough data issues with testing, but you ain't going to pick that up. 2 of the 3 things aren't accounted for in epi modeling, at least what we had seen and what we knew. And here's another problem. And the CDC was also building the plane while flying. So, and this wasn't nefarious, and there's nothing I'm going to say here that hopefully they wouldn't agree to as well. They didn't give guidance on PPE usage. What was the right stuff to use, how you should use it, what you should think about. All right. So what we're doing is we're saying, I don't know how many patients are coming. I don't know how much PPE we're going to use, but I got to forecast it for 64 hospitals. How's your all's magic 8 ball? Because that's what I felt like at that time. How big of a problem is this? People who don't have confirmed COVID. This is daily hospitalizations in West Virginia as a percentage of COVID suspected patients. We're going to call them suspected patients to COVID confirmed patients or total patients. So think about this as we have total COVID protocols on this many patients. These are the percentages. Now I can't show you the raw numbers for obvious reasons, but on day 1, May 1, when we finally deployed our model, 60% of all hospitalizations in West Virginia were COVID suspected. 5 days later, it was closer to 75. Hey, that's a big number. Looks like it's closer to 85 now. Our epidemiological models aren't built to account for this type of setting because they're built to say we have surveillance and we know. Here's the problem. You don't know. You have no, like, you don't know. You're not 100%. You don't get all that testing. All right. It's not wrong. Like, these models aren't bad. It's just they're not built to handle this. All right. As statisticians, as people who work on data, we know there's models for almost everything, right? But we couldn't find one for this because we had to start considering, how are these suspected people moving? What happens? So what we do, we build our own. If you're familiar with epidemiological models, you'll recognize this top piece as a SIR model. Suspected, infected, recovered. And from hospital operations perspective, especially early on in the pandemic, there was the Philly CHIME model, CHIME. It was something that they posted and Code for Philly. It was a great open source initiative. They built it in Python. I would have much preferred they built it in R, but that's just me being picky. But what happened in the way we think about it and the way we start talking about this is people move through this. You're susceptible. A certain percentage will become infected and then they will recover. And we move everybody through this. At some point, we say everybody gets infected or the disease dies out, right? That's the hope. And with COVID, we hope the disease dies out. But then there's this other piece. We actually have to move people through this in hospital operations, which means we have suspected COVID patients. And some of those suspected COVID patients are going to be like, hey, you know, everybody was hyper vigilant in April and May. They were watching people's lungs. They were watching how you breathe. Like, we want observation and eyes on all these people, partially because we have the capacity to, because nobody was doing elective procedures, right? So we have to go from suspected to you're under COVID protocols to, hey, you tested negative. Get out of this, get out of COVID protocols, go someplace else, get to another part of the hospital so you're not exposed anymore. But that creates a secondary susceptible population. So we have two susceptible populations, two what we have to consider infected populations, because that's what's utilizing resources. And the whole goal is to get people to that the second they touch that. So what's it look like? When we plug everything into that model and start running things across with all the parameters we had, what we see is we get a lot of different things going. And this is over a 200-day simulation just to show you what it looks like. Blue line's total hospitalizations. Green line, suspected cases. Red line's confirmed cases. The way we built this model out, these parameters, the infected and recovered, this was how long was the infection. All right. We moved it based on the average infection. This was how long did it take you to get a test back? All right. How long could I take you and figure it out? Are you actually infected? Or have we just been using PPE on you? All right. And I'm not saying that's a bad thing. Hospital care, protection of frontline workers is extremely important. We should have been super cautious. But we still have to estimate these things. These we estimated using the doubling rate. How quick does this thing double? Now, there are other parameters we could have used there, but it was early pandemic. We didn't have serial intervals to do real-time reproduction numbers. We didn't have any of that fun stuff. This is April, May 2020. Everybody was guessing a little bit. So we used what we could estimate from the state of West Virginia. All right. Now, as we go through this and as we kind of see, you'll see there's a couple of different things. We had to use a percentage of infected people that were to actually be hospitalized. We estimated that through a bunch of different ways and talking to people who are a whole heck of a lot smarter than me at about 2.5%. And then we could scenario plan to say that, okay, we could do 1.5, 2.5, we could kind of move it across the board. But as this came up, this is what we would do. So what would happen is we would tell someone, hey, look, here's the projection for this hospital. Because we have to define what the market share is. We have to define the susceptible population. We have to define all these fun things, right? How do we do that? We use market share data. And I'll show you where we got that from here in a second. But the entire idea is to create a forecast like this for every hospital in the state, with that blue line being the only thing that matters, because that's what they have to prep for. That's what they have to know is there. 64 of these every week. And hope you're right. So where's our data coming from? Well, nobody had data on this. There's not a system that combines EHRs, your electronic health records, with ERPs. And that's enterprise resource planning tools. So like, how do you get your stuff? Where are your gloves coming from? Where are your masks coming from? All that fun stuff. And for privacy issues, you don't want a lot of things hitting your electronic health record. I think we can all agree with that, right? Like, privacy is a thing, but there's no way to combine these. There's no visibility on these. Even hospital IT systems are like, I got to pull that from here and that from here and that from here. And I got 64 of those that we got to put together. So our partners at the West Virginia Hospital Association did a daily survey and asked a bunch of questions. How many suspected COVID patients do you have? How many COVID patients do you have? How many beds do you have open? How many? 64 of these reported it every day to us. Now, how do we know the susceptible population of each facility? I'd be lying to you if I didn't say we took a good guess. What we did was we used county level admission data to ER. So the Hospital Association compiles this report and it talks about ER admissions and I'm losing my words right now, but releases. So where do people leave? Where do people go to after they leave the hospital, right? What county did they go to? So what we did was we created market share information off that and said, what percentage of people leave this hospital and go home to there? Because my guess is they're coming the other way too. They're coming from home to that place. We took regional market share information from each facility. We cross-referenced it with census population data, and we created a market share to say each hospital is responsible for this percent of the 1.792 million people in the state of West Virginia. And we go there. Now we know that, state borders don't stop people from crossing them and going to seek healthcare other places, and it comes the other way. But we had to take responsibility, and what you'll figure out is the way you're being benchmarked in this is against your total population, 1.792 million people. People were seeking healthcare in West Virginia, great. We'll have stuff for them because we believe it'll kind of flow both ways. People choose to seek care in Virginia, Maryland, Pennsylvania, Ohio, Kentucky, but their residents will also seek care in West Virginia. So again, we planned for 1.792 million people and hoped it ballparked right. We talk about daily doubling rates. Those were tracked by the West Virginia National Guard based on testing from the Department of Health and Human Resources in West Virginia. Now, rates were calculated from each county Department of Health and aggregated over the footprint of each EMS region. West Virginia is a big state. We've got 11 EMS regions. We said if an ambulance was going to take you to these hospitals, that's probably where you're going to seek care. So let's look at that footprint, and that's how we came up with the susceptible population. Hospitalizations are then calculated as a rate of the historic infections relative to the hospital footprint. Basically, who's going to go where? You're not going to seek emergent care at a small clinic. You're going to go to one of the major hospitals, right? You're also going to be routed to these hospitals through other things. If you show up at one of those small clinics I showed you, you may wind up here in Morgantown at one of the major hospitals. Okay, it just depends. There's a ton of local information that not everybody had access to. I can't tell you this would work for every state. We did it based on the data we had and the data we could use. And it mixes epidemiological and business concepts. So again, we're talking about operationalizing epidemiological models here. How do we use them for actual hospital purposes and hospitalizations? And then what do you do about PPE? Because there's nobody giving you good information on that. The CDC isn't saying, hey, this is the required kit for COVID patients. Hey, this is what you could be wearing. Every hospital could do what they wanted, how they wanted, if they could get their hands on it. So we had the Hospital Association send out a PPE survey 3 times a week. How much do you have? How long will it last? And we cared about gowns, N95s, surgical masks, gloves, and eye protection. When you think eye protection, think goggles. Okay. And I'm going to say this in the nicest way possible, in the most professional way possible. Data and data collection evolved with national priorities. We designed this survey, and then because we didn't want to put undue burden on the hospitals, we were asked to change the survey. We asked for best guess, give me to the day how long you think this lasts you, given surge conditions. And then our friends at the national level came back and asked for, oh, they can bend it. It can be 1 to 7 days. And I'm going, 1 to 7 days is a lifetime in this. Well, then it can be 10 to 15. We can't even just do standard weeks here, guys. Like we can't just bend it in these ways. And so you could have a model up and deployed for a month, and then it would change in one of the surveys, and there was nothing you could do about it. So again, dynamic environment, the ground's always shifting under your feet. Now it's just math. We have facility level forecasted number of patients and facility level PPE usage per patient. It's just math. We've just been doing this all along. Oh, it's 8th grade algebra. Without taking you through all the math, because I do want to get to the other stuff. We monitored and successfully maintained supply for 65 weeks. We never had a shortage in the state. Yeah, but I'm a stats guy. How'd my predictions do? Purple line, actuals. The green and gold lines, forecasted. Blue line is what happens if you don't consider the suspected cases. Now, what we're doing is looking at total patient days cared over a 30-day predicted period. I told you 60, but everybody understands a month a little bit better. So what we did was say on May 1st, how many patients do I need to care for over the next 30 days? How many patient days? Turns out, using just this base epidemiological model that we, I'll say fixed to consider suspected cases, statewide, we were only off at the max by about 25 patients per day. Here's the major issue. I'm okay being over. I'm not okay being under. If we're over, that means we have enough supplies. We've planned enough. People are covered, right? Your N95 gets a cut in it. That's fine. You've got another one sitting there. If you're under, you're asking questions like, well, how do I sanitize an N95 in a microwave? And we figured that out. There are ways to do it. We got really, like we said, ain't nobody coming to save us. So you better figure out how to do all this stuff. And that's one of the great things about having the National Guard. They were able to test. They were able to see what can you do. Point I'm trying to make here is that blue line ain't okay. I'll say it in my own hillbilly way here. That blue line ain't okay. I'm okay being over, but we got to try and get it close because again, these are taxpayer dollars. Everybody's okay if you can tell them their frontline workers are protected, right? This means you're short. Things we learn. National COVID-19 models are not one size fits all. I appreciate what Johns Hopkins COVID tracker is doing. I think it's a great project. That data is useless to me. I do appreciate what they're doing. They're publicizing all the things that are happening, but the way it's tracked, the way it moves, the way everything's there, it doesn't work well for these type of models. The democratization of data science is an amazing thing. But in some of this stuff, it created noise because there were times I was having to answer to legislative leaders about why this says that and why this model online says that. And it's like, they're built for different purposes. They're built for different ideas. Data literacy for the instructors on here. If there's one other thing it's pointed out to me, I need to do a better job teaching data literacy personally. That's one of the challenges I'm taking on after this is because can we talk about what these things is? Can we think critically about data? PPE usage varies greatly among facilities. You'll see those lines there. That's actual stock supplies for hospitals around the area. Won't tell you which one it is. Left panel, surgical masks, right panels, N95s. You see how they burn through it. You see how they ship it. You see how everything moves. The other thing we'll figure out is large scale problems can be solved through collaborative partnerships. And let's talk about collaborative partnerships a little bit, because that just took us to September 2020. That was a pretty fun summer. You know, got to hang out a lot with my kids, like lived in my basement for a little while during quarantine periods. You know, that was fun, right? Then we got really excited because a vaccine showed up. I don't know about you guys, I did. Like I got real excited about that. We formed what was called the GIADF. State's task force is the engine driving West Virginia's vaccine success. And no, we did have early success here because of some decisions we made that other states didn't. This was a March 8th thing. My appointment to the GIADF started January 15th, when I got a phone call from General Jim Hoyer, who was the Adjutant General of the West Virginia National Guard, saying, hey, apparently there's not a system to do vaccine distribution or demand. We had opted out of the federal pharmacies program to begin with. And I'll explain why here in a second. CVS, Walgreens, Walmart, and Target, they're in town. What's that mean? That means it's that 45-minute, hour and a half trip to go there, right? And that's who's giving the federal pharmacies doses. If you've got a shot at any of these places, awesome. I love the fact you got your shot, but you got a federal entity's dose. Or excuse me, you got a federal pharmacy's dose. The other thing is, remember I mentioned there's like 10,000 long-term care facility beds in the state of West Virginia? We have an elderly population. We have a population that is highly at risk. Remember that 50th and Kaiser Family Foundation index about health? We got to get the most vulnerable people shots first. So what we did was we opted out and we used mom and pop's pharmacies across the state using state allocated doses. What that means is they were given to the state of West Virginia for their population. And we got them in nursing homes. We got them to the 65 plus population very quick. Remember I told you about Jim? He was 3 days away when he got diagnosed. And that was beginning of January. Was really, really proud of how we rolled it out. I'm still proud of how we rolled this out here. Now, the things you have to understand, shipments require boxes or trays to be ordered. We're a rural state. We got 55 counties. We got to figure out how to divide it up over those 55 counties and how people move. Demand, it's sparse. It's going to be hit and miss in some areas. And then we're fighting dis and misinformation. Like, you want to see what drives me crazy right now? That last one. I'm trying to stay politically agnostic to everything and every piece of the conversation we have here to give you guys the truth, the whole truth, and nothing but the truth, because I think that's what the conversation deserves to be. But when you're fighting that last thing, when you're fighting the, when you're fighting some of the things I've heard, what do? You try and tell the truth. You try not to get in the arguments. You try not to yell louder than the other person. The other thing you have to know is demand will exceed supply. I don't know how vaccines work where you are, but I got mine in an old Sears that's turned into a warehouse. I cried. I'm not going to even lie about it. I was super happy that day. Next day, it knocked me on my butt, and I've never been happier. Like, I was so happy to be sitting there eating popsicles. Like, it was a great day. So the other thing you've got to understand is we had to define priority groups. We had to set expectations about when shots were going to be available and when vaccinations were going to be available. Just because I worked on this doesn't mean I got a shot early. My second dose was on April 2nd. The only reason I know that is we moved houses that day. So I got to go give my shot and then had to carry boxes and couldn't lift my arm above my head. All right. Other thing you need to understand is the cadence and the rhythm. Vaccine distribution. Who needs what? That happens Friday to Tuesday. So the Joint Interagency Task Force is made up of a bunch of different stakeholders in the state. So think Department of Ed, Department of Health and Human Resources, Department of Corrections, Pharmacy Board. I can just go down the list. If you think they need a say in vaccine distribution or want vaccines for their workers, hospital association, hospitals themselves, long-term care facilities, like, keep going. Think of it as a board made up of about 15 groups. And we've got General Hoyer sitting over the top of it. Okay. He's the one who was tasked to run it because he's run emergency responses in the past. GIADF stakeholders serve as liaisons with providers to get needs. So what they do is they're calling around. Hey, what do you need? Hey, what do you need? How many doses do you need? Do you need Pfizer or Moderna? Are these for prime or boost shots? Prime or the original dose, boost that second one. Or do you need J&J? Do you need Janssen vaccines when we had access to those? What do you need? How can we get it to you? And then what they do is they start piecing everything together. What do I mean piece everything together? Well, we've got to order them in boxes and trays. So you call somebody back up and say, hey, are you good with being Team Moderna for this? Because that would fill out a tray. Or, hey, can we combine these two orders and get them to where they need to be and ship them separately? How does that work? Because the way this works is you send one order to the CDC and they ship it exactly where you tell them it needs to go. All right. Wednesday morning, we have a first review. Demands put together by Tuesday. GIADF stakeholders review demand, confirm needs. They go through and they look at it order by order. Everybody would sit around a big conference table. What do you need? What do you need? What do you need? And they do this all in Excel sheets before they met us. Microsoft Excel is a great program, not for this though. Now, GIADF review. GIADF leadership reviews requests, allocates based on priorities and federal allocation. You're going to ask for the world. Somebody has to keep it down to here's how much we have to give. Here's who we have priority vaccination statuses for. And we've got to make sure it gets there. All right. Then we have something called a distribution plan. This distribution plan is how vaccine will be allocated to these different groups. And it comes from a group called Task Force Vaccine, part of the National Guard. What they do is they take their logistics officers, they sit down, they put it together, and they publish a plan. They publish a plan. The distribution plan to 5 hubs and the GIADF. And 5 hubs are where we gave out vaccine. Everybody had to go pick it up from these 5 places in the state of West Virginia. 55 counties, 5 spots you could pick it up from. And then I can't spell, but distribution of vaccine. All right. Get shots in arms. They go to the hubs, they pick it up, and it's gone. Now, you guys are going to think of a hub like an Amazon warehouse, because that's what it sounds like. It sounds like a place where they're just cranking through, passing out vaccine. Now, I want to remind you of something. Vaccines are about that big. Those vials are really tiny. Think of this as a room in a hospital with a fridge. All right. And I know in the state of West Virginia, we have the safest vaccine anywhere on the planet, because I walked in one of those rooms and I had 5 National Guard members staring right back at me. And one of them was the size of the fridge. And I was real happy about that, because ain't nobody coming to take that. But it's also how they secured it. They treat vaccine here as this critical entity, because it is. One of the things we know, and again, apolitical, just being honest about data, I know. One of the things we know right now, get a shot and it keeps you out of the hospital. Not going to guarantee you're not going to catch COVID, but it keeps you out of the hospital. It keeps you from stressing the healthcare infrastructure. So if anybody on this video chat or anybody who listens to this doesn't have a shot, please, 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 please get a shot. All right. Now, what's this distribution plan look like? Different colors represent different areas of the state each hub's responsible for. You'll see where the little black dot is. That's where the hubs themselves are. That's where those fridges live. All right. So everybody's going to those hubs. Now, we called this from need to needle to arm. That was the initiative. West Virginia's Emergency Inventory Management System, what we're going to call EIMS, is designed to provide West Virginia leadership with full visibility into vaccine distribution. That's the system we built. Version 1, which rolled out 3 weeks after the first time we were asked. I didn't sleep for about 3 weeks, and I'd never spent so much time coding in my life. All right. It's a Shiny-based solution with 9 applications developed in what we call a hyper agile. If you're familiar with software development, you're familiar with the agile program. All right, agile programming. We rolled it out in 3 weeks. What we meant by hyper development is if you're used to production level code, you're used to testing environments, you're used to, hey, can this merge appropriately? Hey, can it do all this? Nope, we didn't get that. We were developing on production. Like everything you would ever teach a student not to do, we did. And I have no qualms about it. Did we cause errors? Did we shut down vaccination distribution at times in the state because I couldn't get a comma in the right place? Yep. But it was fixed in 2 minutes and we were gone. We were moving again. Okay. At that time, for version 1, only leadership needed access. And we were living through dynamic changes in vaccine distribution, different priority levels, different demand signals. Vaccines were being approved at different times, right? I mean, think about it. We knew about Pfizer and Moderna, but then J&J got approved too, right? So all these times change and all these things move. Now, version 2 came along. We kind of trimmed it down a little bit because each one of those 9 applications got spun up real fast. When somebody asked for something, we were like, okay, just create a new app for it. Give them the URL. Like we'll use it that way. With version 2, we had a bigger request that I'll walk you through in a second. It was a management portal and a provider portal. The provider portal, think of it as your vaccinators. They're your doctors, they're your hospitals, they're your pharmacies. They had to be able to access it to order vaccine through us. To the point where these slides were created, we assisted in over 1.6 million doses of vaccines in West Virginia residents' arms. That's a good day. Currently partnering with other states and countries to share this tool. We've got a Docker image that has this thing in it. We've been contacted by 3 countries and a bunch of other states saying, wait, how'd you do that? Because this same model is how West Virginia gives out water during water crises, how it happens and all this stuff. We can change vaccine to water, paper towels, food, all that fun stuff, and it works. That Shiny application that we're all like, yeah, this created a really cool dashboard. We're running as a full inventory management platform right now. Again, $85 a month. So principles of the EAMS development, because this isn't our conference and this is software. One of the things we were able to do was spin this team together because I knew what they knew. Myself and Catherine were the 2 main developers. Hannah joined us during version 2. We have hyper agile development. What we mean by that is scope changes by the hour. You could be told, hey, build this, and 10 minutes later, you get a phone call saying, wait, don't build that. Like, no, stop. We don't need that. We need it to do this instead. Or you go to test it and they're like, well, that's not what we said, because everything was done through text message, emails, and phone calls. You want that good scope of a project, you need to work on something else. Requirements are dynamic. The thing you have to accept is errors are going to occur. And the thing you've got to be able to do with any sort of thing you create is you've got to empower the end user, because they're your decision maker. There are no state or federal systems. There was nothing that exists. You guys may hear about the wonderful thing called VAMS, right? That records all the data from vaccination. That's the only thing out there right now, besides what we can record normal vaccination. But there's no, this mass vaccine ordering and distribution, especially when demand exceeds supply, isn't something easy to do. The other thing we have to think about is a minimum viable product. What's going to get shots in arms? People have like nice requests like, hey, can you make the interface prettier? That interface isn't going to help me get a shot in an arm tomorrow, right? So we came up with the statement, that's a tomorrow problem. And sometimes tomorrow never comes. There's a good Garth Brooks song about that. Now, we also had to have a small footprint. We didn't use a large database. There's no database structure behind this thing. All right. You guys are going to go, wait, no SQL, no, like even like Postgres. That costs money. That costs time too. We have to make this stuff show up in real time. So one of the tricks we used was figuring out how to limit user access to flat file writing. It can be done in Shiny. Shiny's really good about it, and you get real smart about it real fast. What you have to consider is what user has access to what are they writing, where are they reading? Is it a read or a write, and how often can they write? And then setting and queuing properly. Small servers, again, we can't set up these huge systems. We got to keep it small footprint. All right. And then we have to keep it cheap and open source. These are taxpayer dollars at the end of the day. And at some point, there's going to be an audit on what we did. Like, I mean, that's just a fact of how it works with government spending. They're going to audit, what did we spend our money on? How did we spend it? And that's a fair thing to do. Now, a couple more things. And I know I only have a few more minutes, but I'm just going to walk you through the iterations. Our first development took a Shiny server, created these apps, stakeholder upload and GIADF management. What would happen is stakeholders would be able to upload an Excel spreadsheet, give demand. When I talk about stakeholders, what I'm talking about is the entities in the GIADF. So Department of Education, we get to upload one for teachers. Higher ed, we get to upload one for colleges. Department of Corrections to protect corrections officers, all those things. They'd upload a Microsoft Excel file and kind of go from there. GIADF management is where we got to do the review. Hey, do you actually need this? How does this create? And everything's writing and reading, okay? So you can write and read. The only place we're seeing true engagement is at the stakeholder upload. Everybody else is just downloading a document. What happens is an email goes out to the hubs. I put a big Amazon warehouse on here because, you know, I know that's mentally what everybody is, but remember, room with a fridge, all right? It goes out in an email. It is a static file as far as they're concerned, but there ain't nothing static about vaccine distribution. Imagine pickup times any place. People can't get from point A to point B, right? They give it to the vaccine providers, providers give shots, and then next go around, they ask the stakeholders. Again, that's version 1. That was minimum viable product to get vaccines starting moving outside the door. Before the applications were created, everything was done in Excel spreadsheets, and nobody could tell you where anything was. We still had some problems. The hubs were using Excel spreadsheets because that's what we sent them the distro as. They were using Google Drives. They were using what we called secret squirrel documents to keep access to it. But the other thing you're not thinking about, you're thinking about just the vials. What about the gloves? What about the needles? What about the syringes? What about the different variations of it? So what this application did was it tracked all of that. It didn't just track vaccine from point A to point B. It's you need 300 doses. You're going to break 4 needles in those 300 doses. You're going to go through gloves. You're going to need these different syringes because it's what's recommended for these different variations. So you got to think about what's there and what can work. Now, the CDC shipped a bunch of this stuff, but when you start talking about needles breaking, it just depends. We're doing mass vaccination clinics. People are trying to move as quick as possible. So here's version 2. We added these 2 applications, Hub Operations and Leadership Visuals. Hub operations gave real-time dynamics of who's picked up, what has changed. Because there's times where people say, hey, I ordered 100 vaccines, but I re-looked at a bunch of people cancel. I'm only going to use 75 vials. Can you take these 25 vials and use them someplace else in the state? And the answer is absolutely. Yes, we would love to put on a vaccine clinic in one of these rural areas tomorrow, right? So when you're looking at this, what we did was we created a way for hub operators to come in and say, yes, this has been picked up. Yet, no, this hasn't been picked up. Hey, this order changed. So what we're doing is we're creating this dynamic environment now where things reading and writing all the time from a data perspective. The arrows are on data flow and how things flow through the application. And then we created this leadership visuals because the question is, how many vaccines are still at this hub during distribution? How many of these things should have not gone out? So we've really got hub operations attached back to the Shiny server. So we're creating real-time visuals at the GIADF in Charleston, allowing them to interact to say, hey, we've got a bunch of excess Moderna here that people didn't pick up. Let's put on a vaccine clinic in an underrepresented community. Let's go, let's take it to Berkeley County. Let's take it to downtown Huntington. And here's the last one. We had 2,000 providers. Now, what we had to do was get real smart about how to use AWS and put an elastic file system and mount the drive on there. Use 2 Shiny servers. By separating the Shiny server, we restrict who has access, which means the vaccine providers can never have access to the management applications and the way we create the distribution piece. All they're allowed to do is actually request vaccine. We keep these separated and we still have a stakeholder review piece. Now, I know this entire application is a lot. And I know, I planned for an hour. And I'm going to use every second of it. But the idea here is we got real cute with this at times. Minimum viable product with Shiny. Give them 2 applications where they're at least able to process and view information. To now, every vaccine that's given through state administration comes through this system. The code we've written, I'd say, is master's level data visualization course. Now, we had to get real smart and we tested some things. We learned some things very quickly, which is in an environment like this, you never want to write in production, duh. But 2, we had a lot of programmers working on the same applications at the same times. Everybody has a slightly different style, right? So we had to unify styles very quickly. What helped was I taught it. So your students kind of take on your style sometimes for better or worse. And I won't tell you I'm the best programmer walking. But again, from this AWS file system, what we're able to do is allow these 2 Shiny servers to communicate and move data across them at all times. But by keeping the Shiny servers separate and using AWS Cognito, we're actually able to put a firewall in front of these where the vaccine providers, the people who are giving shots, can't access any of the management applications. And again, if you go try and search for these, I changed the names. So you ain't gonna find the applications living any place. And if you do, please email me so I can move them again. But it's one of those things where this is kind of the design we had and the structure we had. So I want to thank you for your time again. I want to thank the organizing committee for inviting me to do this. Hopefully this was useful. We didn't really get a chance to talk about vaccination numbers, which I would tell you if you want to see West Virginia's vaccination numbers, please go to the DHHR website. You'll see today total population, we're about 56%. Of the eligible population, we're about 64.5%. Here's the ones that I'm really, really excited about, which are our 50+ population, which is close to 80% first dose, and our 65+% population, which is close to 90% first dose. So really, really excited about that. And that's going to look a lot different than what you see in the quote unquote papers of record. And that nice CNN article that came out 2 days ago about West Virginia's vaccine status. So again, I really appreciate y'all's time. Hopefully this was interesting. Hopefully it was useful. Thank y'all, and y'all have a great day. Stay safe, stay healthy.
Thank you so much, Brad. There have been a few questions coming in through the chat, but just in the sense of we're a little bit into the break, I'm just going to send those to you. Would you mind putting up answers just in like the README on the GitHub if we do that?
Yeah, no, I can definitely do that. I'm more than happy to do that.
Okay. Excellent. So Christina just posted in the chat if you're going to stay for the next talk by Fiona on Beyond, to the Basics and Beyond on our Shiny apps, stay in this Zoom chat. Otherwise, you'll need to switch over to see the scenario planning talk with Frank Corrigan. And so we will go to break and then be back at 1:30. And if you want to use the little clap button, show Brad your appreciation or clap in your video, Thank you so much. Again, this was awesome. And we'll see you guys all back in about 12 minutes.
Appreciate y'all. Y'all have a good day.